speaker is in Nevada, and due to the time difference, he's kindly shared with us a pre-recorded lecture, and he'll join us for a 10-minute Q&A at the end. Today we're welcoming Dr. Riddle, who is Director of Pfizer Vaccines Clinical Research and Development and Professor of Preventive Medicine at the University of Nevada, Reno School of Medicine. He brings more than 2 decades of combined research and development, public health, academic, and clinical medicine expertise, while serving as medical corps officer in the U.S. Navy, as well as research leadership positions at the University of Nevada, Reno School of Medicine, and the VA Sierra Nevada healthcare system. He spent nearly 2 decades in developing vaccines to develop common deployment-related infections, as well as exploring the frontiers of science and the epidemiology and mechanisms of chronic gastrointestinal disorders. In addition, Dr. Riddle has led development of national and international guidelines in the management of travelers' diarrhea. He has authored over 250 peer-reviewed scientific publications and book chapters and serves on multiple editorial boards. So without further ado, we welcome Dr. Riddle.
Welcome to the practical aspects of traveler's diarrhea for the clinician. I'm Mark Riddle. Sorry I could not be live on video, but the roosters have not yet started crowing out here in California. So I will be giving this pre-recorded talk, and I'll be available to answer any questions at the end. So I'd like to organize this talk around the 4 enigmas of traveler's diarrhea. Wait, you're saying what? There's only 4 questions about traveler's diarrhea? Well, no, I get a lot of questions about traveler's diarrhea, but I think these are the most salient ones, and that is whether to treat or not to treat. Have microscopes gone the way of the dinosaur? So what? It's only diarrhea until it isn't. And should we be content with current treatment strategies? So you may not have thought about traveler's diarrhea in this way, but it's a very broad area that can be considered. You see here the multiple columns where there's gastroenteritis, or there's non-inflammatory diarrhea, or there can be inflammatory diarrhea. Traveler's diarrhea encompasses persistent abdominal symptoms. You can also get neurological manifestations from enteric infections while traveling. And then there's systemic illnesses that can occur. Within each of these clinical syndromes, there can be multiple causes: viruses, toxins, bacteria, parasites. Persistent abdominal symptoms or post-infectious complications can be the interaction between the infection and the host. And so it's very complex and a wide spectrum. And I'm not going to focus on all of this, but just wanted you to appreciate that it is a diverse area and something we're learning more and more about each day. So how big a problem is traveler's diarrhea? Well, like I say, travel is on the rebound. Prior to the pandemic, you see here data from the International Tourism World Bank. There were 1.3 million trips of international tourism departures. Now, some of these may be Europe going to Europe or North America going to Europe, but you see here this graphic in the bar chart where within the Asia Pacific region, about 23% or 25% of those are actually going to low and middle income countries. Europe, it's around 10%, and in North America, it's as high as 40%. So how big a problem then is traveler's diarrhea? Well, getting my envelope out and doing some quick calculations, we see that about 768 million travelers are going to traveler's diarrhea risk regions, and it's growing. Traveler's diarrhea incidence varies by destination, somewhere between 10 and 40%, depending on itinerary and place. So that equates to about 7.7 to 30.8 million cases of traveler's diarrhea each year. 1 in 20 may develop post-infectious IBS, which equals to, well, I'll let you do the math. So we know travelers' diarrhea risks varies by geographic region, and it may be increasing. Here's a map from a review done by Robert Steffen, Bert DuPont back in 2015. And they quote from their review that the incidence of travelers' diarrhea has decreased in countries with increasing economies and in some previously high-risk destinations with improved tourism infrastructure. And overall, they noted that the incidence of travelers' diarrhea is declining. However, I think it depends maybe on those kind of secular changes of hygiene improvement, but it may also depend on other factors such as the traveler type and the destinations where people are going. And in fact, in my work within the Department of Defense that I did a few years back, we looked at what the change in incidence over time was across a 20-year period. You see here a meta-analysis where we published in 2006 and then repeated that same study in 2019, looking at what is the changes in incidence over time among military and long-term travelers. And when we limited it to deployments or travel to the Middle East, because that was comparable, we actually found that there was no real change between the period of 1990, 2005, and 2005 and 2015. So perhaps in some travelers, the incidence is going down, but I would argue in other travelers, it may be staying the same. So what do recent data on populations and settings suggest? Well, interestingly, data from pilgrims on the Hajj show that in fact, the risk of enteric infection and travelers' diarrhea have gone down. And this is largely attributed to the fact that there's continued implementation of measures to improve the quality of food and water and sanitary conditions during this mass gathering event. However, on the other hand, we're seeing that student travelers are observed to have continued high risk. Among medical students from European countries, the per trip incidence was between 46 and 48%. And among students going from the US to Israel, travelers' diarrhea rates were around 70% per trip. So I think while there's some population settings where it's improving, again, I think in others, the risk remains quite high. So with that backdrop of travelers' diarrhea, the growth of travel and the burden among travelers, it brings us to our first question: to treat or not to treat? And the origins of this question of to treat or not to treat is sort of interesting. And it actually comes from this observation over the last several years where we are seeing travelers being colonized with multi-drug resistant organisms, specifically extended spectrum beta lactamase producing E. coli. Here you see a fairly nice review from the Canadian Communicable Disease Reports, which describe the rates of travelers returning with incident ESBL PE colonizations from different parts of the world. And clearly there is a regional effect in Asia. But there are other risk factors that include, and this is where the controversy around treatment comes from, is using antibiotics to treat diarrhea or antibiotic use in general, as well as diet as a risk factor. So what we know about this is that this colonization is transient for most people, but not all. We don't really know the health impact on the traveler. This has not really been described, just that they become colonized. We don't know that this contributes to the spread of resistance. That's not been described. And we do need to have concern for some vulnerable travelers where this could be a problem. For example, an elderly traveler with recurrent UTIs, a acquisition of one of these multi-drug resistant uropathogens could be a problem. Travelers who are from a vulnerable household or workplace, and those who might be having procedures after travel. So this all has led to quite a bit of debate in the travel community and messages of caution of antibiotic use. So recent findings have confirmed, but also been different than what's been reported in the past. And I just want to run through a couple of recent papers. So recently, a cohort study of about in 2016, 2017, among 230 German travelers, again, they do find a colonization rate of about 23%, and risk factors include age, the accommodation, location for sure. But when they looked at antibiotic intake, it trended, but wasn't statistically associated, maybe because it was a smaller study. There was a cross-sectional study among 303 Swedish travelers with traveler's diarrhea. They found a 28% new colonization. And it was interesting that this study was a repeat of a similar study from 10 years ago and found similar rates. Again, Asia and Africa were the highest risk areas, and there was no information on antibiotic use or other risk factors. Among military travelers, 64, which included 72 distinct trips, there was a 11% colonization rate. Again, Asia was travel was the only risk factor. And then in a in a study of 90 Hong Kong travelers, interestingly, they looked at, or most all these studies look at the colonization prior to travel. And in this one, it was quite high at 45.6%. And then among the remaining 49 travelers, there was a 40% acquisition, eating raw seafood, and diarrheal illness in the 3 months, but no risk factors were found for traveler's diarrhea or antibiotics, but again, small numbers. This brings up the notion of the risk of introduction and health consequences of these multi-drug resistant organisms among many people who travel from high income to low income areas and vice versa. So with that as background, I wanted to talk to you about what the current recommendations are for treatment of traveler's diarrhea. And I had the great fortune of working and leading a effort sponsored by the International Society of Travel Medicine and the CDC Foundation to develop guidelines on prevention and treatment of traveler's diarrhea using the GRADE criteria. This is freely available, so please, if you're interested, go ahead and there's a QR code there that takes you right to it. This was done quite a few years ago, but it's still quite relevant, and not a lot has changed that would change this guideline, in my opinion. And I want to go through this figure that you see on the right in more detail to provide what current recommendations are around these guidelines. So the first part of these guidelines dealt with pre-travel counseling, which is often the first opportunity to have an impact on traveler's diarrhea in the clinical setting. And here we came up with or decided upon 5 different recommendations. And one is to consider counseling the traveler on the definitions of traveler's diarrhea and severity classification, and this will be important in a moment. Stressing the importance of oral rehydration and fluid intake for traveler's diarrhea. discussing the effectiveness of treatments for traveler's diarrhea and risk of travel and antibiotic use with the potential risk of acquisition of multi-drug resistant bacteria, providing empiric treatment medications that's specific to the itinerary, and then emphasizing intra and post-travel illness follow-up recommendations. And so with this pre-travel counseling, information is needed to give the individual, because again, in this case, you're actually, the traveler is diagnosing themselves and making decisions on treating, and you're providing them information on what the severity of diarrhea is, and because that dictates treatment. And so there's mild, which is diarrhea that's tolerable and does not interfere with planned activities. Moderate, where it's distressing and may interfere with planned activities, and then severe, which is incapacitating and would prevent planned activities. And severe is also stratified by whether there is blood in the stools or no blood in the stools. So depending on the determination of the severity of the traveler's diarrhea, it dictates what should be treated. So if it's mild, it's recommended that you may use loperamide or bismuth subsalicylates. This will control stooling and cramping, though it won't shorten the duration of illness. Moderate, it is suggested that you can use loperamide alone or as an adjunct to antibiotics. And then for severe, non-dysentery, you may use loperamide as an adjunct to antibiotics, and you should use an antibiotic for severe. And again, moderate, you may use an antibiotic with or without loperamide. So I want to talk a little bit more about the evidence of these recommendations and specifically talk a little bit more about the nuance of how and what we should treat with. So currently there's a number of different antibiotics, dose ranges, and regimen durations that one can choose. You see here, azithromycin is preferred in Southeast Asia. That's due to the fluoroquinolone resistance that's seen there. Whereas rifaximin, which is at the bottom of this list, is recommended only for areas where you don't have fever and blood in the stool. And so this can sometimes create complications because you don't really know whether somebody's going to have watery diarrhea or bloody diarrhea. And so you want to avoid providing multiple different types of antibiotics to the patient. I think one thing that I want to focus on here is that there is strong evidence for single dose therapy, particularly when it's adjuncted with loperamide for moderate to severe watery diarrhea. And I'd like to walk you through some of that evidence. So there was a systematic review done, more than 20 years ago now, where this was in the era of doing studies on traveler's diarrhea to determine whether antibiotics versus placebo improved outcome. Because again, we didn't really know the etiology of traveler's diarrhea. Now we do. Now we know it's around 85% to 90% bacterial. And in this systematic review done by the Cochrane collaboration, they identified 6 articles that compared a number of different types of antibiotics to placebo and found that antibiotics across all of these randomized controlled trials improved the clinical cure at 72 hours. And I think that this is an important point, 72 hours. And the median time to last unformed stool, so that means after they were treated, they were randomized and treated with the intervention, the time to last unformed stool, the median time was around 30 hours. Untreated, it's around 72 to 96 hours, just for reference. So we extended these observations, and the field started looking at not only antibiotics, but then adding loperamide in adjunct to those antibiotics. And we conducted a systematic review published in 2008 that compared regimens of antibiotic alone versus antibiotic with loperamide. So antibiotics alone or antibiotic loperamide. And instead of the odds of clinical cure at 72 hours, we looked at odds of clinical cure at 48 hours. Again, we found 6 different randomized controlled trials that looked at, again, various types of classes of antibiotics and regimens, as you can see here. But all but one, and it's the Cipro 750 milligram single dose, showed an advantage of the loperamide adjunctive regimens compared to antibiotics alone, with a combined odds ratio of around 2.6 for clinical cure at 24 hours. Furthermore, the median time to last unformed stool, instead of 30 hours with antibiotics compared alone, it was around 12 hours. So a remarkable improvement of something which will last 72 to 96 hours if untreated, to around 12 hours once you start therapy. Now, that one study that showed no association needs to be put in context, in that was conducted in Thailand, where it is known that there are high rates of fluoroquinolone resistance, particularly against the predominant pathogen of Campylobacter. So overall, these data support that loperamide, in addition to an antibiotic for watery diarrhea, provides a distinct advantage. It was thus in this backdrop that led myself and colleagues to undertake a large multinational randomized trial that we call the TREAT TD study, to look at the value, the efficacy of effectiveness of adjuncted loperamide in single dose regimens of the 3 classes of antibiotics that had been used. So before this time, we knew that antibiotics worked. We knew that loperamide was an improvement over antibiotics alone, but there was all this question about, well, what about single dose regimens versus multi-day regimens? And so we designed a study that took place among deployed military personnel, both UK and US, in Afghanistan, Djibouti, Honduras, Kenya, and Thailand, to evaluate all single-dose regimens of rifaximin, 1650 milligrams, levofloxacin 500 milligrams, and azithromycin 500 milligrams, with primary outcomes of clinical cure in 24 hours and time to last unformed stool. It was powered to be a 360-person study, a non-inferiority trial.
Yeah.
So funny. Yeah.
Well,
Slide the bar forward a few seconds.
Essentially, what we found was single dose works. It works equivalently for all 3 different antibiotic classes. You see here this Kaplan-Meier curve of the 3 antibiotics looking at the event of time to last unformed stool. You notice a rapid effect in about 25%, where after you initially dose them with loperamide plus the antibiotic, they have no further unformed stools. that's the loperamide kicking in. What we see then is that essentially over the observation period, that if you look at median, it's about 4 to 6 hours, or mean around 14 to 15 hours time to last unformed stool for all regimens, and very, very few treatment failures. So here's a little pro tip on how I practice. And when I see a traveler or myself, for every 2 weeks of travel, I take 3 500 milligram azithromycin tabs and about 10 loperamide. I recommend that as soon as the illness starts affecting travel or the itinerary, that you begin treatment. Single dose works, but if you're not better after 24 hours, you can take another dose of antibiotics. And if you have high fever or blood in the stools, you should avoid the loperamide. So, as mentioned earlier, given the concern about the antibiotic use in travelers' diarrhea and the risk in acquiring multi-drug resistant Enterobacteriaceae, we had the opportunity to look at this in this study. Although we didn't have any placebos to compare that to, but thinking back, the historical rates of ESBL acquisition are around 20 to 65% in studies to the regions that this trial was in. We think that, that many antibiotic regimens are multi-dose and multi-day, and so a single dose regimen ought to biologically have less of a pressure on the microbiome and the replacement of that, or the creating the niche for these drug-resistant bacteria. And in fact, what we saw in this study, and I know it's complicated, but I will bring your attention to the paired subjects where we had pre-treatment and post-treatment assessment for multi-drug resistant bacteria. Overall, first we see low rates, which is fairly typical of high-income countries in terms of pre-treatment. But even after treatment, across them, we see an average of only about 10% acquisition. Some differences in the particular antibiotic regimen, but overall much lower. And I think that this really drives home the importance of judicious use of antibiotic, and given that single dose antibiotics work, that should be something that is understood and utilized. I'd like to further provide context to this controversy and draw your attention to this paper a few years ago that was published by The Lancet, that was a very systematic and critical review of understanding the mechanisms of drivers of antimicrobial resistance across many different routes of transmission and contribution. And you see here is a graphic that defines the evidence for the factor contributing to antimicrobial resistance being low, moderate, or high, and the relative contribution of the factor as a driver. Clearly, human antimicrobial use and animal microbial misuse or overuse are high drivers and high quality of evidence. You look down towards the bottom, travel in the reddish color, the evidence that the factors contributing to microbial resistance is low, and the relative contribution of that factor is moderate. So in context of these other causes, travel is probably not a primary driver. So wrapping all this up, and again, we addressed this in the guidelines, I'd like to talk through where I think things are. One is, in the guidelines, we do recommend that pre-travel counseling include information about the risk of multi-drug resistant acquisition balanced against the benefits of antibiotic use. And I do believe judicious use of antibiotics is warranted, and single dose therapy given that it's effective as multi-dose day courses, and there's some evidence to suggest that it's less likely to induce these colonizations, should be used. The conversation comes to balancing the risks and benefits of global health, of the local community, and of individual health. And these are tough conversations to have and to convey and to get across. But on balance, I think that due to the risk of traveler's diarrhea occurring, the consequences, which I'll speak to in a moment, and the potential risk of antibiotic use, on balance, treating traveler's diarrhea should be the norm. So before we move on to the next enigma, what's new on the horizon beyond antibiotics? Well, the microbiome studies have been done in travelers to see if particular microbiome types create resistance. There are some interesting findings, but there's nothing consistent, and we don't know well enough how to modulate the microbiome. Probiotics do not work in preventing traveler's diarrhea. That much is clear. There are some early discovery efforts looking at phage directed towards specific bacteria that are commonly causing traveler's diarrhea, like Enteroagrega E. coli. And then there are microcin research on microcins, again, directed towards a particular pathogen that predominantly causes traveler's diarrhea, called Enterotoxigenic E. coli, or ETEC. But these are problematic. Making them, defining them, refining them, giving them, not having resistance developed to these are important questions, but this research is interesting to follow. So this brings us to our next enigma, and that is, has microscopes gone the way of the dinosaur? Well, I'd like to introduce this and credit to a close colleague of mine, Brad Connor from the New York City Travel Clinic. Talk about a case study to introduce this. So this is a 24-year-old female student from a 6-week abroad summer education experience in Kenya. She presents with diarrhea, abdominal pain, and nausea, which has been slowly progressing over the past 10 days. During this 6-week, and this is after she comes back from her 6-week rotation, she did say that she had an acute bout of traveler's diarrhea after she arrived there earlier in her experience, and she treated it successfully, and she thanks you very much for the azithromycin and loperamide you provided. Her past medical history is unremarkable, no history of IBS, takes oral contraceptive and allergy medication, and she presents afebrile, in distress, diffuse abdominal tenderness, and hyperactive bowel sounds. So being that you are in a clinic, you order a test to understand what's going on, and you're using the PCR tests that are becoming more broadly available. And this is your result. So there are 2 different types of diarrheagenic E. coli. There is 2 different parasites, and there is a virus. And the question is, what do you do with this information? Well, first, according to guidelines, acute traveler's diarrhea should really just be treated empirically, and that's whether you're in Kenya or you're coming back from Kenya or Mexico and you have acute traveler's diarrhea. There's no real need to do diagnostics. You can assume that it's traveler's diarrhea, bacterial etiology predominant, and treat accordingly. In our guidelines, we recommend that microbiological testing is recommended in returning travelers with severe or persistent symptoms, or in those who fail empiric therapy. And when you are doing diagnostics, multiplex molecular diagnostics are the preferred in patients with persistent or chronic symptoms. And that's in fact what's going on with this case that I just presented with persistent symptoms past of about 10 days. But again, you have to be prepared for the kind of results that I showed you. We published with Brad Connor and Greg Martin a update on how to interpret these PCR panels in the context of diarrheal disease, particularly traveler's diarrhea, published in the Red Journal a couple years ago. And there are certain clues that are important not only to the test, but also to the patient's history. So understanding the quality of the diarrheal illness. Was it sudden onset? Is it associated with vomiting of short duration? That could lead to a viral suspect. If its infection is travel related, certainly bacteria is high on your list. If its infection is travel related and the symptoms are persistent but wax and wane, or they developed insidiously, or they didn't get better with antibiotics, then think parasitics. And then, you also need to consider non-infectious causes. So are the symptoms persistent? Was there no associated with travel or high-risk exposure? All of these historical details and the clinical presentation need to be understood and used with these PCR diagnostics. So returning to this case study, this person had treated before, was coming with a insidious slow onset over the past 10 days. We know that in travel you acquire pathogens that are sometimes asymptomatic, and based on these findings, it's likely that one of the parasites is the cause, not the virus, which wouldn't be producing long-term illness, or the bacteria. So the rest of the story is that the patient was treated with nitazoxanide, 500 milligrams for 3 days, and the symptoms completely resolved. Okay, on to our third enigma of traveler's diarrhea. So what? It's only diarrhea until it isn't. So I appreciate you indulging me for a moment as we go down history lane, and wanted to draw your attention to two individuals: Sir Arthur Hurst, who was a British Army medical officer, quite renowned during World War I, and Montezuma II, who was the last emperor of Mexico. Dr. Hurst published this in 1918, this Medical Diseases of War book. And I'd like to show you what he wrote in one of the chapters. I believe he described probably the first account of post-infectious irritable bowel syndrome that exists in written history. And in one of his chapters, he writes, patients who have recovered from an attack of dysentery frequently remain unfit for a considerable period, which may even extend to years. He goes on to say that most cases, the patient suffers from alternating attacks of constipation and diarrhea. He describes discomfort and fullness immediately after meals, and that a soldier's heart may be present, meaning that there may be some psychological comorbidity. And he also notes that the severe abdominal distension developed 4 to 8 months after the patient had apparently recovered from the attack of dysentery. So it's important to say that, back in World War I, in this period, they called everything dysentery, whether it was bloody diarrhea or watery diarrhea. But I think that this is remarkably similar to how we described post-infectious IBS. Now, many more studies that have been done since that time have been more rigorous in their design and case control studies defining the true risk of post-infectious IBS. But I'd like to return back to the story of Montezuma and Hearst, and I believe that we all know Montezuma's revenge that it accounts for. So since then, countless studies have been done, and I think there's been 3 or 4 now systematic reviews which define the association between enteric infection and the risk of post-infectious IBS and other functional GI disorders. But I want to return back to this story of Montezuma and Dr. Hearst. We know Montezuma's revenge is one of those monikers that people give about when they go to Mexico and they get diarrhea. And the story behind that is that Montezuma, as he was the last Aztec emperor of Mexico, as he was dying, due to the Spanish conquest, he put a curse on the land that any foreign person that returned would become ill with acute diarrhea. I actually think that he was even extending this to the chronic consequences of acute diarrhea as part of the revenge. And I've set up a GoFundMe site that you can contribute to send me to Mexico for about 6 months while I research that. But in all seriousness, getting traveler's diarrhea increases your risk of getting IBS more than 3-fold. And here's one of those systematic reviews that was published a few years ago. These are limited to just studies among travelers, and we do see some heterogeneity among these studies. And we know that that age is associated, where you have lower risk as you get older for developing post-infectious IBS. And a number of these studies that are described that have a lower effect estimate for the risk are among older travelers. But we also know that infection length and severity is at risk. And so, again, going back to the treatment of traveler's diarrhea and the effective treatment, if theoretically, if one could reduce the duration and the severity of traveler's diarrhea through early and effective treatment, one potentially could mitigate the risk of developing post-infectious IBS. Now, this has not been tested formally, but again, I think this is something that we need to pay attention to. Lastly, on the topic of traveler's diarrhea as the gift that keeps on giving, there are observations that are emerging that describe persistent abdominal symptoms that occur after travel. And it doesn't meet the classification of post-infectious IBS, and it can be associated with a pathogen, associated with something that sometimes is a pathogen, and the findings of whether or not usually a parasite is contributing to symptoms or not is uncertain. There have been experiences in people with these persistent abdominal symptoms who are treated with a anti-parasitic agent, but don't have any evidence of parasite, get better. And so, this is something that is emerging in the travel medicine community to understand these types of people with persistent.
Yeah, we should pause if there are questions.
I think we're having some issues with the sound of the video. So our speaker is actually on our Zoom, so we'd like to pause here and invite any questions from the audience.
Hey, this is Mark Riddle. Sorry, I could not be there, and I'm also seeing that there were some glitches with the recording. So I'm sorry. I apologize in advance about that as well. Hope everybody's doing well.
Hi, thanks for joining us.
Thanks for joining us, Mark. I had a quick question actually with Ali Lavanos here, who you know as well.
Yeah.
You're talking about the post-infectious IBS. Do we know if certain treatments decrease the risk of that in acute illness, or any associations there?
So with what we don't know yet, but I think it's prime for study, is some sort of a intervention that occurs when someone is acutely ill with traveler's diarrhea, or it could be bacterial. We see post-infectious IBS a lot with Campylobacter, which is a very common problem in the United States and elsewhere in the world. And there have been studies with like E. coli 0157, where they've tried mesalazine in combination or in treatment, and it's reduced the risk of post-infectious consequences there. It hasn't been studied yet. Like, can you treat it early and does it go away? The only data are that the longer duration of the illness and the more severe duration, the more risk there is. In terms of treatment, it's really managed by a lot of current practices with IBS. Although you do see these effects of small intestinal bacterial overgrowth that occur, again, 6 months after someone recovers and are developing IBS. But there's no treatment per se, and I think the mechanisms that are involved in post-infectious IBS are many like the mechanisms that we see with idiopathic IBS.
Mark, this is Jean-Fred. This was amazing, very interesting. I have two questions. Practically speaking, when one course of antibiotics doesn't work, what should you do? Because if the success is not,
yeah. So
imagine that I'm in that country, I'm taking this one course, it doesn't work. So
that's a good thing. That's a good question. So that rarely happens with most travel-associated diarrhea. Again, the cure rates for antibiotic are quite high, but you do have that occasion where you don't get it. I will generally then, if I've tried a course of antibacterial therapy and there are persistent problems, I will try a course of metronidazole to see if that works. Else, it's going to be a very rare outcome of some unmasking of some other disease that need to be. And so I tell the patients that I see, if you don't get better, you need to follow up, you need to get seen. And at that point, if I were in the United States, I would also get PCR testing done on my stool to see what might be there.
Okay. And Mark, so when imagine you are traveling tomorrow to this kind of country, to Africa, what will you take in your in your suitcase?
So in my kit? Yeah. So I generally will take, I'll take non-diarrheal medications, but I will take azithromycin and loperamide essentially, and then for treatment. I don't take Flagyl or anything like that, probably because I don't go on trips that are that long where I think I'll need it. If I do need it, I would go try to find a local pharmacy, and get something like that. But I exclusively take azithromycin with me on my travel with loperamide. And again, I take, for every 2 weeks I go, I take, 3 500 milligram tabs and about 10 loperamide. And that will
and again, I'll only take a single dose if it's watery, but if it's dysentery, I take the full 3 days. So yeah.
Thank you, Mark.
Yeah, no, I appreciate the opportunity. I think it's interesting if you have time, looking at these slides, and again, I'm sorry about the glitches in the recording of it. The amount of investment that's going on right now in long COVID and post-infectious complications of COVID is it's like $34 per US person with post-COVID. With IBS, it's like 90 cents, so it's just there's an incredible burden of disease of post-infection, and a lot of infections cause these chronic consequences, but there's not the investment right now, I think, in understanding these post-infectious functional bowel disorders. And C. diff's another one of those things where you see post-infectious, it's mostly on the complication side. But again, there's more research, I think, that needs to be done in this area of GI, chronic GI consequences of acute enteric infections.
And Mark, actually, you have published some data on IBD as well.
Yeah, I think we have done epidemiologic studies, and there are now, this would be good if anybody in the audience wants to do a systematic review. There's plenty of articles now for looking at the risk of inflammatory bowel disease after enteric infection now, and they universally they show an association. I think the issue with these studies are in that there's some confounding in that the symptoms of enteric infection will often be misattributed or Crohn's disease or whatever, misattributed to these infections, and they'll get workups as well because they think it's acute enteric infection. And so, to tease out epidemiologically these risks are hard, although, there's plenty of studies, Yasmin Belkade at the NIH and Tim Hand now, who's at Pittsburgh, have done some really nice studies showing how infections really prime the risk for these autoimmune autoimmune like inflammatory bowel disease after an infection. So, I think there's something there as well. Epidemiologically, in mice studies or animal studies, it's been shown. But it hasn't been fully understood as well. And we look for it in our study, it's hard to interpret. Problem is serologically to identify evidence. These infections, you get a rise in your titers for about 3 to 6 months, and then they go down. And so it's very difficult to ascertain prior history of enteric infections.
Mark, I have one quick practical question that maybe it's just bogus, but I remember people sometimes telling me that you can consider taking Pepto-Bismol kind of prophylactically while you're traveling to help decrease the risk. You feel like that
those are like, if the talk got like 5 more slides in, you would see that. So Pepto-Bismol, there's a large phase 4 randomized controlled trial with Pepto-Bismol right now that's being done to look at prevention. Right now, there's 3 studies out, two that are published, one that was industry, and then just published in a systematic review, and it shows about a 50% reduction. And so, in absence of any other prophylactic right now, the Pepto-Bismol may be something to try. You have to take it frequently, it gives you black tongue and things like that. But anyway, I wish I could stay longer. I actually do have a hard stop right now at 6. I'm supposed to be on a training call, but again, sorry about the technical glitches. Thank you for the opportunity to present. Happy to talk with anybody. Can send me a message if they have any follow-up questions.
Thanks so much, Mark.
Dr.
Bye.
Riddle.
All right, good seeing you all. Bye.